Missed our latest webinar? No worries. We know life gets busy, but your professional development shouldn't have to wait. That's why we've created webinar micro lessons. Short, focused recaps of our full sessions designed to help you catch up quickly and still earn your CPD points. These bite-sized lessons are available exclusively to active subscribe members. So even if you miss a live session, you never miss out on the knowledge or the CPD points. Not subscribed yet? Now's the perfect time to join. Get access to all future webinars, every micro lesson, and more. Visit www.clinicalcareplatform.com to sign up.
Hi, colleagues. You caught me red-handed. Taking a sip of water, preparing to host you. Good evening. Good evening. How are you guys doing? Yeah, you don't know, when the week begins, I always look forward to this evening sessions because I miss you guys so much. Maybe we should do them every evening, every Saturday, every Sunday. I don't know. But I always say, "Ooh, when is the next webinar?" So yeah, just to appreciate you and to say thank you very much for joining us, this evening for the ophthalmology webinar series. And you know me, I'm never alone. Look who's back. Look who's back home. Dr. Bufokeng, Thabiso, welcome, brother. You good?
I'm good, thanks, Doc. I'm good, and good evening, colleagues.
Yes, thank you. Thank you. We really want to appreciate you for making time for us. We don't take anything for granted. We know the life of a medical doctor, add the specialty on top, and you realize how hectic things can be. So we just want to say thank you for including us in that squashed time. We really, really feel very, very special. So, colleagues, just to do some introductory note, and then we will go through today's topic. Today, we are looking at issues of the eye and the red eye. As I was taking my tea, I said, red eye, what am I going to ask Dr. Mufokeng? But let me wait for you to teach, Doc. I have a unique question for you. Hopefully,
Okay.
you'll be ready for this one. It's something that they won't teach you, go and med. This one requires you to be, but it's a fun thing. So, yeah, so our mission
Okay.
as a platform is to improve patient care. And the eye is a very important organ without which there's many things we can't do. So I believe that this webinar really aligns very strongly with our mission to help you at the cold phase, primary health care, primary care from a general practitioner perspective, but also from a nursing perspective. We also have some ophthalmology nurses I know who have joined, working in a hospital setting. So I know that it's going to be a very empowering session. We continue to celebrate having issued over 100,000 CPD credentials to yourselves. We want to say thank you to our members, people who join our master classes, and importantly, our collaborators like Dr. Mufogeng, because it's a platform. You know, we need those who want to learn and those who love teaching to come together to create this incredible experience. If you are not a member of the platform, I encourage you to join in. Remember, all our evening sessions are open access. Whether you're a member or not, please just join in, because we want you to be empowered. But if you want certificates, CPDs, you know, all those kinds of things, you have to be a subscribing, paying member. So yeah, I really like that. And yes, you know, since we did the time management through leadership, we always share leadership moments. And I think yesterday or this morning, I can't remember, the colleagues who are in that group, our leadership group, will remind me. And we were talking about that every single day matters, you know. And even today, I want to make sure that you make sure that today counts, you know. So many people miss moments. Even this moment, this particular hour, try to be present, you know, in this moment. Try to make the best use of it. And one of the reasons is, remember, a moment that passes is in the past. We can't do anything about it. Tomorrow is not assured. Tomorrow is uncertain. What we are sure of is this moment, and the next hour you're going to spend with your kids, the next hour you're going to spend with your loved ones. Make sure that that moment is a masterpiece. You spend it, you know, and as you spend it, check your own emotions, how you feel when you are with your kids. How do they feel? I think that's when you're going to appreciate why every moment in our lives matters. And it's just a leadership note to you to make sure that no day goes to waste, but we appreciate the opportunity to still be alive. And yes, if you are our member, you have additional micro lessons which are CPD accredited. You can take them at your own time. And maybe linked to today's topic, the ophthalmology, diabetes, and the eye lesson is already there for you. Just log in on the platform, enjoy it, learn as much as you can about the eye. But there's so many more that you can learn. And yes, our academy is growing. So we have a number of CPD accredited paid courses, from the basic HIV management to NIMART for nurses to cardiology, pulmonology, hey, dispensing. So if you need some specialized e-learning courses, do visit our academy there on the website. But let me not bore you with my issues. I know you are here to learn about the eye, and importantly, to learn, why is it red? Why would the eye, you know, become red? Is it because I'm so exhausted and I just woke up, or there's something very serious? And we really want to appreciate Dr. Tabiso for continuing to commit his time to empower us on the eye. And I say the eye is like the skin. I know internship and community service can pass without you having rotated in these two disciplines. And that means most of us are not necessarily very capable to assess, to diagnose, and to respond to ophthalmic issues. And before I introduce Dr. Tabiso, just to say that we have a masterclass coming next month on common ophthalmic emergencies. So please get ready, include us there in your budget. Someone said we are finishing their 950s. Chef, I understand. We will repeat it again, you know, next year. But if your time allows and your budget allows, please include us in your budget. We are requesting. We are knocking. We are knocking on your purse. because I think it's going to be an empowering and fulfilling experience. We are also thinking of working on coaching those who want to write the college diploma in ophthalmology. Hey, CCP. Yeah, this world can never be the same again because there's now more and more professionals who are competent. And Dr. Taviso is our medical practitioner, he's our specialist ophthalmologist. He also has that postgraduate diploma in ophthalmology, but also he's a qualified specialist, having both the master's program from VETS, but also the fellowship from the College of Medicine of South Africa. He is a general ophthalmologist in private practice at Safe Side Cataract and Eye Lasers. And next time you must give us a technology-based talk, Doc, on this laser stuff. We want to see exactly what's happening there. And it's actually here in Johannesburg, Morningside, in Sandton. Colleagues, let's welcome Dr. Taviso with all the hearts you can give him as we give him a chance to try and share his slides. Welcome, Doc. This is your home now.
Thank you, Doc. Let me see.
Don't allow those hearts to intimidate you. They don't give me so many hearts when I teach, but you know, I'm just being jealous. If you go to your lower right tab, remember next to your, yeah, there, and then you put it on full screen. The next one on your right, the next, yeah, that one. Yes, thanks, Doc. Can just pull it on your,
Double click.
yeah, click once, or yeah, give it a
It's
few
fine.
seconds. Do you want to get your pointer now or later?
Maybe let's get it now.
Yeah. There you go. Lace. Aha.
Okay.
Awesome.
Yeah,
Awesome.
we've got it
Colleagues,
now.
this is it. Let's go for gold. Thanks, Doc.
Thank you, Dr. Mawela. Thank you, colleagues, for making time to give me basically to learn about this elephant in the room, the red eye. Um, Firstly, I must just declare that I've got nothing to declare because I'm going to be mentioning some management in some of the cases, and I might name drugs by their names. So maybe it's just because that's what I prefer or that's what I'm familiar with, but I've got nothing to declare. So our topic for today is, of course, approach to a red eye in general practice. Uh, I feel that, I might have taken too much a bite to chew because, red eye is quite a broad topic, but I'll break my talk on the purpose for this discussion and then maybe a brief anatomy, and then we'll go on to the common causes of red eye and maybe a stepwise assessment of a patient with a red eye. And we should try to come up with a toolkit in terms of what we should have in our rooms or in our ER or in our primary healthcare facility to be able to come up with a correct diagnosis. And maybe and then I'll go in and do a few case presentations. I thought I'll ask some few questions as well as we do these cases, but because of time, I think I'll ask the questions and even give the answers so that we can cover as much as we can. Now, patients with acute ophthalmic symptoms often present to their family physicians or their primary healthcare physicians. In a British medical journal, it was stated that 68% of primary healthcare givers report uncertainties about managing eyes, and 10% reported to be stiff scared. A study in Australia showed that 64% of red eyes are misdiagnosed by their primary healthcare facilities, and 10% end up with serious adverse events, with serious consequences. There is a tendency amongst clinicians to diagnose infective conjunctivitis in any acutely red eye, whether bacterial or viral, but it's conjunctivitis it's a common diagnosis, even when it's not the right diagnosis. And this will obviously delay appropriate treatment and unnecessary loss to vision in some cases. So by the time we are done with this talk today, I want us to have achieve whereby we can improve the quality of acute red eye consultations. And this we do by applying simple yet high-yielding intervention strategies. And whatever we come up with, it must be applicable at any general practice, and it must be cost effective. So we don't expect people to invest in things like slit lamps and all these other devices that we use, but we need to come up with a toolkit basically. So just a brief gross anatomy of the eye. Obviously, my focus is on the ocular surface, so basically on the outside of the eye, starting from the lids, the lashes, the clear cornea, the pupil, whereby you must also obviously assess the pupil size. A normal pupil size is about 2 millimeters. The conjunctiva overlying the clear sclera. The sclera we regard it as the skeleton of the eye, is the toughest tissue in the eye. And then, of course, the lower lid as well and the lashes. This is just a cross section of the eye. Like I said, our focus will be on the ocular surface. So the clear cornea, that continues with the sclera. And of course, inside the eye, we have the vitreous body. And at the back, we've got the optic nerve. Now, what are the common causes of a red eye? Conjunctivitis, it makes sense why it's commonly diagnosed, even though it's not diagnosed. It's one of the common causes. Dry eye disease, it's also very common and it must not be underestimated. It can be very disabling. Corneal abrasion is also very common. Other conditions, they might not be that common, but we see them a lot. Corneal ulcer, uveitis. And uveitis, I must also add, it can be very tricky in children because they don't have the typical red eye, but so it can be easily missed, whereby like a child has a very active uveitis, but it's missed because it's not a typical presentation. Acute angle closure glaucoma, it's just mentioned there. It's one of those things that one can't miss in terms of the severity of the pain when the patients present. And I guess trauma, the patient will give us that history of trauma, but one must also have a high index of suspicion if trauma is diagnosed in a child, because these days we do have challenges of child abuse. Penetrating injury, this is also very important. It was also mentioned in the niche guidelines. The issue with intraocular foreign body is that one must not underestimate a patient coming to you saying, "Doc, I was chopping wood and I feel like a splinter went into my eye." Never ever underestimate those, because that can have gone through the inside of the eye. It could have penetrated the eye and the eye has sealed itself. But any piece of wood inside an eye, it's literally a ticking time bomb, literally. And then other issues will be things like chemical injury. And often than not, the patient will obviously indicate that something got into my eye, whether I was baking or I was fixing my car, a battery acid. But at least there will be a bit of history. We just have to know what to do when these patients present to us as the entry port, basically. And not forgetting that we do get a red eye as a symptom of a systemic disease. We have a lot of other autoimmune disease that can present starting with the eye, but you find that you are between, it's you and you are the main person who can actually come up with a more serious condition if ever we do these things thoroughly. So I like this niche guideline where they mention that when you assess a patient with the right eye, you must document everything, including the negative findings. So even if you expect that this patient should have a poor view and the view is good, you must include it. It's important. And our assessment would entail three things. Obviously, a careful history. It's important that we mention this because sometimes we get excited. You see a red eye and then you just want to jump into this and to find out what could be wrong, forgetting the basic assessment of the history, because that could give us a good guideline in terms of where we are leading to. We need to come up with a stepwise ophthalmic assessment, a stepwise ophthalmic examination. And of course, we need to come up with appropriate tools that can help us to pick up the correct diagnosis. So on history, I like this mnemonic pulse. When they talk about the red flags, when you talk about the red flags, you must always question about these four things. Firstly, is there pain, and what is the intensity of pain? What is the visual acuity? Is the vision intact or not? Is the patient having photophobia? And if it's there, how severe it is? I mean, if a patient walks to your rooms wearing shades and covering their faces with dark towels, then you know that must be severe. I'm just giving an example. And of course, you want to decide to determine whether is it unilateral or bilateral. And then just to add on, I mean, we want to also find out in terms of is it acute or not? I mean, there's this thing started within the past 7 days, or is it 2 month old, or you want to know the onset. Is there any discharge? And then of course, at that discharge, if it's there, you want to look at it whether is it watery or is it a sticky, purulent discharge? And you want to ask if there's a foreign body sensation. Usually the patients will say, I feel like there's sand in my eye. That's how they describe it. And then it doesn't hurt to also find out if ever there are any other non-ocular associated symptoms, things like rhinorrhea, sore throat, because usually that could also give you a bit of a guideline in terms of what you're dealing with, especially in an acute onset. Any environmental exposures, you want to find out about them, whether is it at work or is there any close contact who has a similar problem. And you also want to find out if there are any use of topical drugs, especially patients on glaucoma treatment. We do end up having patients on prostaglandin analogs, and over 50% of them, they'll have hyperemia. So the eye will look very red. Sometimes it can even look scary, but it's actually painless. And then we are happy because the pressure is low. I mean, that's our intention. But as long as you know what could be the reason. And past medical history is very important. Even sexually transmitted disease, the history of that is important. It's unfortunate that even in this day and age, we still see adults with gonococcal conjunctivitis, and it needs aggressive treatment. So it's important to ask about that, especially looking at the type of discharge. History of a contact lens wear, very, very important, because sometimes the patient will present to you, she's wearing her glasses because she's got a problem with the eye. The contact lenses are left at home. But if you don't ask, you might end up missing a very important piece of information. And any history of trauma, whether chemical injury or blunt trauma, you want to find out. But obviously, patient will also add that to their history as well. Now, when you examine this patient, you want to assess their visual acuity. So, I mean, when you come to our toolkit that I said you must come up with, it's important to note it down. There's nothing as disheartening as a patient coming back to you day 3, day 4 on review and saying to you, Doc, when I came on Monday, I could see. Today is Wednesday, I can't see. And you didn't document it down. So it's important to document your visual acuity, and so that you can even tell if there's any change in the vision. And even for medical legal reasons, it's very important to document visual acuity. You must look at the pupil. On our toolkit, we'll talk about having some source of a torch, a pen torch, some source of light. You want to look at the pupillary responses to direct and concentric light reflexes. Does the eye constrict with light or not? I mean, that's it, and it's very easy to determine. You want to look at the extraocular movements. You want to assess them. We normally talk about 8 cardinal movements. So basically, the patient will look superiorly, inferiorly, medially, laterally, superomedially, superolaterally, inferomedially, and inferolaterally, just like that. And you need to compare the two eyes as you are looking at those movements so that you can tell that the eye that's affected has restricted movements. Even if you just note that, you don't have to grade it, but as long as you can note that there's restricted movements, and it's very important for you to decide in terms of what you're dealing with. You obviously want to look at the external surface of the eye. Is there any rash? Things like your herpes simplex lesions, or like herpes zoster lesions. Because once you see that with a red eye, you know that you're dealing with probably hepatic keratitis, and it will need urgent intervention. You also want to look for any old scars, because sometimes what you call shingles, it will leave a scar, and patients can present obviously as a complication later on with a red eye. You want to look at the discharge, and as we had already said, are there any crust on the lashes? You also want to look at the position of your lids. Is the lid ptotic? Because if the patient has a ptosis, they might not be able to close their eyes at night, and you find they get exposure keratitis, the eye becomes red, and then at least you can still treat them conservatively whilst are waiting for permanent intervention. You also want to look at the position of the lower lid. There's something called entropion. So basically, the lid is bent, is folded inwards, and now the lashes will be rubbing on the cornea. or you want to look at it, do they have ectropion, where the lid is bent outwards and obviously giving them exposure? Is there any trichiasis, whereby basically the lashes are misdirected, they're the ones that are rubbing on the cornea? Or they've got this dystichiasis where there's extra lashes behind the movement lens orifice and they're rubbing on the eye. So just to show a few pictures, obviously this is a little one here with most probably congenital ptosis. So you want to look at both the palpebral apertures. You want to compare the two sides and be able to see, there's obviously a ptosis here. So this type of patients, whilst they're waiting for an appointment with the oculoplastic, they can at least be on treatment with lubricants just to prevent the eye getting dry. Here's an example of entropion. So the lashes are rubbing on the eye. And you can see this also patient is obviously well treated because there's no redness or anything. So these, they will also treat them while we're still waiting for definitive treatment, lubricants all the way. Here's a patient here with ectropion. So the lid is misdirected outwards. So this patient cannot fully close their eye, and then they have this exposure keratitis. So exposure, yeah. So basically, you can see that the eye is injected, and it's because of this excessive dryness. This is obviously after they fix the eye. I think here I just wanted to show this is probably a patient with thyroid eye disease. Usually they'll probably present with proptosis. I didn't mention that in terms of when you want to look, but also want to look if there is there any proptosis. And further examination, after you look at these leads, you want to look now at the surface of the eye. You want to see, is there any foreign body on the cornea? A simple touch, a simple direct ophthalmoscope, you will be able to show that there's something on the cornea. Is there any corneal abrasion? Here, when I talk about our toolkit, I will mention how we pick up a corneal abrasion. Is there any corneal ulcer? You can still see that with a direct ophthalmoscope, but there's a better way of picking it up as well. And then when you find that the patient has a red eye, or you want to look at the pattern of the redness, is it diffuse? Is it localized? Is it superficial? Is the vessels are from the conjunctiva? Or is it deep? Because once it's deep, you will worry, about uveitis or ocularitis or anything more sinister. I just added here corkscrew vessels. So corkscrew vessels usually, for those who use a corkscrew, a corkscrew it's winded like, yeah, basically they are winded like a corkscrew itself. So any patient with a lesion on the eye, whether let's say for example a squamous cell carcinoma, they usually have an associated corkscrew vessels leading towards the lesion. But even any other lesion, not necessarily cancers, but for us, we worry about SCC when we see that. And then you want to feel for the eye if the patient allows you. We just use 2 index fingers. You just gently palpate on the globe itself and you compare the 2 sides. And if you feel like the other eye is hard, you worry about things like a raised intraocular pressure, as we mentioned, angle closure glaucoma. So just to show us a few slides again here, we are dealing with a patient with, it's a kind of a localized injected vessels. This will obviously be your diffuse, superficial, and deep vessels. So this patient probably has a scleritis. This is a mixture between diffuse and localized. Here, I think I just wanted to illustrate that the conjunctiva can also be edematous itself. And then here is actually the corkscrew vessels I was talking about. So actually this patient has a lesion there. It's a pity I didn't do justice with my slide here. So the lesion there, that gelatinous lesion it's actually a squamous cell carcinoma with corkscrew vessels leading towards the actual lesion itself. Now, coming to the toolkit that I've been talking about, when I say we need to have a toolkit to be able to diagnose these patients. A simple Snellen chart, basically a VA chart. It doesn't have to be, like 6 meters and even if it's the one that we use for near, as long as you can have an idea that this patient at 1 meter, he could read up to 6/6 vision or up to 20/20 vision. A pinhole, some of you might have seen it. Basically, it's a plastic that is it's usually opaque, like it's not transparent, and then usually has a 1 millimeter hole. These are for patients whereby like you find that as you're assessing the visual acuity, the visual acuity is a bit, let's say 636 is decreased, you want to rule out a refractive error. If they don't have glasses, you ask them to look through a pinhole. If it improves, you know that there's an element of a refractive error, and that obviously will reduce your anxiety in terms of there's poor vision, you know. And then a source of light. So here they talk about pen light with blue filter. But as I've already mentioned, your direct ophthalmoscope, you know, when we buy these sets, I know through my GPTs, you know, we used to buy these ENT sets. Most reps, they always say to you, you can also buy an ophthalmoscope. I used to have that. So the nice thing about this ophthalmoscope, the direct ophthalmoscope, it's obviously handheld. It has blue filter. It has clear light, but you can switch it to blue filter, and it also you can also measure the disc with it in terms of if you look through the aperture on it. And then fluorescence strips, that's what we normally would use if ever we want to detect if ever a patient has a corneal ulcer or an abrasion. So these fluorescence strips, they are available. They usually come in a pack of hundreds. And you usually we just put the strip and you put a drop of saline or an anesthetic drop, and you want to stain the eye. So it will stain the eye. It's usually yellow. When it stains the eye green, but with blue light, yeah. So with blue light, it will turn green. I'll just show you a few pictures of it as well. So in your toolkit, you want to have those things. You also have a red object. Usually we use, you know, our dilating drops. They usually have a red top. So you want to assess, when we want to assess the color function, this is just the easy way of doing it, where you just shine light on that red top, and then you just adjust the intensity of the light, and you want the patient to grade it, to tell you which one is much more brighter. But the right way is to do the Ishihara, but this is allowed to use in an ER situation. And then here they just added that you must have a red flag symptom card. Whereby like we have a card that says I must have asked those four questions, the red flags that I mentioned, that mnemonic pulse. And then in addition, I think you must have a topical anesthetic drop. We usually use Novacin. I'm sure there's others as well. And then a cotton wool and an eye patch if ever you need to obviously cover the patient, those especially those that have photophobia. But the cotton wool, you also sometimes want to assess if if the cornea is sensitive or not. But because with some ulcers, you find that there's loss of sensitivity of the cornea, especially with hepatic keratitis, with herpes simplex and herpes zoster. Now, coming to management, you know, we need to come up with a criteria to say which patients am I treating, which patients can I treat and refer later. So basically, I want to tell whether is this critical or non-critical. So what is going to give us guidelines? The intensity of pain, the duration of symptoms. Like I said, if a patient comes with a 3-month history of red eyes, I mean, vision is intact, you can try to figure out what could be wrong, but it's obviously non-critical. You want to check if it's bilateral or unilateral. And once you decide if it's critical, you still have to decide whether is it urgent or elective, like I was saying. And for the non-critical cases, whereby like you said, no, this is something that we can treat, you need to have an expected period whereby like you say, you know what, if after 30 days this patient is worse or he hasn't recovered, what should I do? So you need to have it in mind that I must see these patients, and for all my patients, especially with acute red eyes, I gotta see them within 3 days. And obviously, if ever it's something like a viral conjunctivitis, you expect it to improve within a week. So you need to have an idea that when do I expect full recovery, and that will obviously give you a guideline in terms of what to do next. Uh, I'm just gonna go through a few cases. First case, this is a 30-year-old gentleman. He presents to your rooms with a 2-day history of a persistent, diffuse red eye. It's a right eye. It is also watery. It has a watery discharge and a burning sensation in both eyes. And he also mentions that he's got a bit of a rhinorrhea. There's no history of allergies or significant past medical history. There's no environmental exposures, and the vision is intact. What else did you want to ask this patient? I'll go straight to the answers. As you ask, he responds that yes, I mean, actually had flu for the past 3 days. And he also adds that there is somebody in the family with a problem that the daughter started crutch a few days ago, and she also had an issue with her eye. You examine this patient, the vision is intact, 6/6, and then the right eye, he's got those dried crusting on the eyelids. He's got diffuse hyperemia of conjunctival vessels and a watery discharge. The cornea is clear, the pupils are equal, round, and reactive to light, and the left eye has got just mild hyperemia and watery secretions. So this is the patient I'm talking about. So here the leads, you can see the border of crust on the lashes there, there's diffuse hyperemia, but the vision is intact, the cornea is clear. So what could be happening with this patient? So before you want to manage the patient, but you need to come up with a diagnosis. Is it infective or is it allergic? But already he told you he doesn't have any history of allergy, so it's most definitely infective. But is it viral or bacterial? It's pointing to virus because the discharge is watery. It's very, very, what do you call this? It's contagious. The daughter had an issue with this and is even giving you a history of flu. So already we know that you are dealing with most likely adenoviral conjunctivitis. This you don't have to, this is something that we can treat. I think we can all treat this. We don't have to be wasting time for the patient. This is like textbook stuff where they say you must give lubricants and cool compressors. Unfortunately, most of our patients, they come very aggressive. So you need to give them something to take home as well. But of importance is that there's no need to swab this patient for culture. All you need to do is to make them comfortable. The disease will run its course. For me, my take-home thing is I always give them a topical antibiotic, and specifically the ointment. And we know this is possible, it's a virus, but for me, the ointment, firstly, it works as a lubricant, but it also, I guess gives you peace of mind that there won't be any secondary bacterial infections. Is there room for mild steroids? Almost all my patients, they need a mild steroid. And I think as much as they say under the supervision of an ophthalmologist, as doctors, we can start patients on a mild topical steroid, as long as we know which one. For example, my go-to is Lotemex or Alrex, and it's a minimal dose, a daily dose. The main thing is just for them to use the ointment. And of course, it's important to know that it's not one size fits all, because sometimes a patient comes with us and then we still give them this mild steroids because Mofo can say it's safe. So it's important to be sure what you are dealing with. And that's why I'm saying when you give these patients treatment, call them back in 3 days. And in 3 days, you call this patient back, there's no improvement, then you might consider maybe I should refer this patient. But if the patient says, no, doc, I'm feeling better, even though you think they're not improving, you can call them back in a week. And you can still safely, as long as when they come, you still assess the vision. It's important. On any review, assess the vision, assess them like you haven't seen them before. Just do a full, thorough assessment. If these patients develop any lesion on the cornea, they were not there, but now he's got something on the cornea, you don't waste time, you refer. Or a patient reports poor vision, of which you can also assess. When you do your visual acuity chart, this patient was 6/6 or 6/12. Now she's 6/60 or 6/36. You have to worry, and you can still say, you know what, I'm referring because there's a change in vision. If the patient comes and we still feel it's a viral conjunctivitis, it's fine. The only thing is, if ever we miss something and somebody says, but why didn't once you saw the red flag, vision changed, why did you keep the patient? And then another thing that they mention is that if the patient develops membranes or pseudomembranes, you can refer them. And if the pain becomes worse. So I just thought I should illustrate to you these membranes that we're talking about. So these are pseudomembranes, that whitish lesion there, that whitish membrane layer there. That's what they can develop with when they get this viral conjunctivitis. So the reason why we want them to be referred, because we don't want this to complicate and form what you call symblepharon. Because once this develops, now this patient has to go to theater, because they can be more than one of these symblepharons, where you find the tarsal conjunctiva is adherent to the surface of the eye, So basically, this patient can't close the eye properly, and now you're gonna get other problems. So usually these we send them to theater, and then we remove these. They'll always bleed, but at least we remove them, and then we do other procedures like we put. Anyway, I'm not go too deep into the management of what we do on our side, but basically, when they develop these membranes, it's safer to refer them. Okay, the second case, you've got this 28-year-old executive female. She presents to you with a 2-day history of left eye pain, epiphora, and a mild red eye. So epiphora basically a tearing eye. On further inquiry, she mentions that her 6-month-old scratched her on the face and on the left eye while she was breastfeeding. What could be the most likely diagnosis? I actually got a phone call last week Friday about a patient, almost a similar story. And I just told the colleague that just stain that eye. So there's the fluorescein strip that I was talking about. This is fluorescein, and you shine a blue filter light, it will turn green. So this patient has a corneal abrasion. That's what we're dealing with there. This we should treat. We don't have to waste time for the patient. We Personally, I just use two things. I just use a topical antibiotic ointment and an iPad if necessary. But now they also mention analgesics. You can still add a topical anesthetic drop like ocular. Like I say, preferably iron, you don't want to be giving patients too many things. But sometimes, you want the patient to be happy. So if the patient is complaining of severe pain, as long as you're sure that you stain that eye and you know it's a corneal abrasion, you can add an analgesic drop. And you want to see this patient in 3 days. Often than not, this takes 3 days to fully reepithelialize. So in 3 days, when you see them, this patient should have been healed. Another scenario of the very same lady, instead of coming early, she decided to come 2 weeks after the incident. The vision is poor. That's what she complains about on that eye. She's got a foreign body sensation. The eye is severely painful. She's got extensive photophobia. She walks in your rooms covering her head in a dark towel because light is so bad on her. What are we dealing with here? So now, because the patient delayed, she developed a corneal ulcer. You stain it, you use a blue filter light, you can see. Okay, some people can look at this and say this is an abrasion. So it's a fine line, but I think I would rather just go aggressive. This is a corneal ulcer, and obviously this is an urgent referral. I just thought I should just share other slides of corneal ulcers. This is a bacterial keratitis. You can see that yellow purulent or yellow infiltrates in the stroma. Now, the only challenge between bacteria and fungal keratitis, they present the same. That's why fungal keratitis, they are always misdiagnosed because we always start with what is common, which is a bacterial keratitis. So that's why it's important that we swab these patients to get appropriate diagnosis. This is another stain. So basically, I'm just emphasizing the importance of having these fluorescent strips, which are really, really easy to get. So this is more of what we call a dendritic ulcer. It has dendrites. So obviously, this you already know clinically. Once it has dendrites, you are dealing with a herpes simplex keratitis. And this is obviously you don't play around. We need to refer, and we need to counsel these patients because once they become to hospital, we usually actually admit them. So we already covered the risk factors of corneal ulcer. We spoke about trauma, but it's important to remember the other risk factors. If a patient says, "Doc, I wear contact lenses," and interesting, it's not even the hard contact lenses. The soft ones are the ones that are more. We see lots of patients with soft contact lens wearers being the one developing corneal ulcers. And I think the reason is because sometimes they're comfortable to sleep in, and patients end up, like obviously doing all the wrong habits, and they end up having this type of problems. Prolonged use of steroid drops. That's why I was saying that it's not one size fit all. Steroid drops, especially the ones that I've mentioned, are very mild. We've got potent ones like your dexamethazones or predforte. We use them a lot, but we need to know because prolonged use, especially if it's used inappropriately, we get a whole lot of other problems. I mean, I've got a gentleman with full-blown glaucoma because he was self-medicating on steroid drops. Um, Severe dry eye disease can predispose us to corneal ulcers as well. Now, what are the complications of these corneal ulcers? Once they heal, they can form a scar. So obviously, it's on the cornea. It will it will interfere with vision. They can perforate. This is the worst one. I mean, if once it perforates, it all goes south. From perforation, endophthalmitis. With endophthalmitis, now there's 50-50. You can lose that eye. You can have a corneal melt. Literally, this cornea melts in front of you. You see this patient every day, but the ulcer is getting bigger and thinner and thinner. You know, it's a bit, we don't have time to talk about the management, but I'm just showing you these complications that, okay. And then I thought, I mean, since we're talking about having a toolkit, the importance of having this fluorescein and even having this fluorescein together with normal saline drops or anesthetic drops, but specifically, so what you do, you do the you put fluorescein again, and then you want to see, this is what you call a Sidel test. So if there's a perforation, you will actually see the tracing of your aqueous as the fluorescent goes in and forms the sediments inside the eye. This is inside the anterior chamber. So that's just the importance of having the right tools, because sometimes it's not easy to see that the anterior chamber is shared or there is a bit of a perforation. Now, with the management of these corneal ulcers, what's important is that the patient must be counseled because in public hospitals, these patients, we admit them. In private practice, they have to come and see you almost every day. So it's important that we both understand. I always say to patients, it's like it's a team. There's a coach and there's a player. He's the player, you're the coach. They know it's a long haul. It can take up to a month for them to be fully restored. So it's, when a patient has a corneal ulcer, I mean, straightforward, you want to admit them, you want to collect a specimen for MCNS, and then you start empirical treatment. Usually we treat them as bacterial, unless if ever it's a clear cut, like, with dendritic pattern and all that. And then you want to counsel your patients on the prolonged stay. Just about 2 weeks ago, I saw a 70-year-old lady who came to me because she's got a corneal ulcer, and she was being seen in one of our public institutions. And she was told that we need to admit you, and she said that I'll come the following day. Instead, she came to me. I had to explain to her that you've got the best chance being inside the hospital, considering that she's a cash paying patient. So I'm just illustrating these things because it's about the patient. We need to counsel them thoroughly when they have got this type of conditions. And if this patient is using contact lenses, it goes without saying that they must stop using the contact lenses until there's full recovery. And of course, you want to counsel them on the right way of storing their contact lenses and, of course, of using their contact lenses. We have patients who will tell you that I was swimming in Val River with my contact lenses, and they come here with acanthamoeba or something because, so counseling is very important. So the third case, I hope I'm still doing good on time. An 8-year-old, but these ones are going to be short. An 8-year-old boy, asthmatic, with bilateral itchy red eyes and a tinge of a brown slit in the background. The mom thinks the problem started over a year ago. It gets worse. It's seasonal, so it gets worse in spring. And it responds poorly to antihistamine drops. There's no visual complaints as yet, because with time, this can cause visual problems. What are we dealing with? Like I said, I'll just go on and give you and give the answers, So this is a vernal keratoconjunctivitis, VKC. Maybe I'm showing a bit of an extreme form, not extreme, but it's moderate. This can still be treated in our rooms. I think once an initial diagnosis is made and confirmed, this can be handed over. Okay, maybe not this, but once they're quiet, you can basically be continuously be treated in our primary healthcare facilities. So you can see there's this brown tinge here, We call these dots Hornatantrus dots. They've got mast cells. The cornea is clear. It's not massively injected. So this one is more acute. They've got this, what you call pseudogerontoxin, these membranes on top. You give them treatment, they respond very well to treatment. We'll come to the discussion as in terms of how do we treat them. Again, here, counseling is important. These patients are going to be on long-term treatment. We need to explain to them that this will go on until up to their teenage years. And if you stop treatment, it will recur. And it's important to understand that this VKC has two pathways. So that's why your allergex drops won't work if you give them alone, because it's two pathways. Basically, it's the IgE pathway and cell mediated. So we need to give a mast cell stabilizer and something that will deal with the active allergy itself. Active yeah. So now, one that we're familiar with is Patanol, but I'm sure there's many others in the market. And then you can add your antihistamine. Most of my patients, I always start them on a mild steroid as well. And like I already said, my go-to is Lotamex or Alrex. And I usually start them on one daily dose, and they do very well. You just see them every 6 months. Now, the only problem with this mild steroid is what you want to check the intraocular pressure. So maybe for that reason alone, you can just stick to the muscle stabilizer and an antihistamine. And if they do well, you don't have to add this, because this, we want to be able to check the pressure every 6 months. But the telltale thing, you always want to assess their visual acuity all the time.
Yeah. Doc, repeat the full name there. Colleagues are asking in the chat. Thanks.
The VKC.
Yes, sure.
Yeah, so it's vernal keratoconjunctivitis.
Okay. Thank you.
Yeah. So I just thought I should just show you the extreme cases of this very same VKC if it's neglected. Fortunately, we don't see much of this. We call this macropapillae. So with these patients, they end up developing what you call shield ulcers, because this is always a rubbing on this cornea. I think this is actually criminal for a child to end up like this, because can be well controlled. The importance of having the fluorescent stains, like I said, you can see this cornea is already not so clear. And then once you do the stain, you can see they've got that uptake of this, even though it's not an ulcer, but you can see that it's a positive stain. In extreme cases, actually, I mustn't say in extreme cases. So there's one thing called keratoconus, where you get thinning of the cornea and it progressively cones out. So it's most cases associated with atopy. So it's associated with things like VKC. And colleagues, so this word VKC, it's actually allowed. It's used. Even if you Google VKC, it will give you the full name. So this is one of those acronyms that are used globally. So the fourth case, 45-year-old gentleman presents you with 45-year-old painful red eyes with blurred vision in the morning. That settles spontaneously as the day progresses. The vision is good. 20/20 vision for distance. They just use reading glasses for near work. He's 45, so he's presbyopic. There's no significant past medical history. Okay, it's a lady. Her work involves a lot of hours on the computer screen, in an office somewhere where there's a nice aircon as well. What are we dealing with? On history alone, this is most obviously like a dry eye disease. It's already telling you she's got usually they'll tell you that I feel like I've got fine sand in my eyes, and it's worse at night, or it's worse when I wake up in the morning. Sometimes when they touch the eye, it's painful as well. So this is dry eye disease. Like I said, it can be disabling. We just need to lubricate these patients, and we've got a lot of many artificial teardrops in the market. I've got my own preferences, but any of them will work. First, you want to reassure this patient. If possible, they must modify their lifestyle. You add artificial tears, as I already mentioned. Very rarely you might have to add very mild steroids, but for a very short course. we have other things that we can do. For example, things like punctal plugs, where we close. Basically, we obliterate the lower lid puncture, but it's a reversible procedure. If they complain that I've got too much tears now, we remove them. So this one is going to be a very quick one as well. 35-year-old executive presents with a spontaneous localized subconjunctival hemorrhage, no history of trauma, no significant past medical history, the vision is intact. What would you want to ask this patient? No history of trauma, like I say, but the two most important things, do you have any bleeding disorder? And secondly, Vasalva, coughing or constipation. We see this a lot, where a patient presents with a subconjunctival hemorrhage, and all we need to do is obviously when they come to me, we'll do a fundus exam as well, because this very same hemorrhage can be at the back of the eye on the retina. We just reassure this patient. You treat the underlying cough if there is, of course, not you, but I mean, actually, you'll be in the right place to do that. If there's constipation, you want to exclude the cause of the constipation, but you can treat the constipation. I'm just showing you this because sometimes people get alarmed and I say, no, go home, you'll be fine. And they're like, but they don't give me anything. There's nothing to give. That thing will resolve on its own. They only complain about the cosmetics, that, but I don't look good, but there's nothing we can do. It will definitely, obviously, usually resolve. 49-year-old, another case, complaining of painful red eyes. She's got photophobia, and they confirm that the redness preceded the pain by a few days. The eye pain is so severe it wakes her up at night. It does not respond to Panado. The pain is worse when they move their eyes, basically on gaze. Let's say on left gaze, right gaze, the pain gets worse. The vision is intact for now. And now they actually tell you, and doc, I'm on treatment for rheumatoid arthritis. So, any patient with autoimmune disease and a red eye, I think it's just better to refer them, because usually the causes can be visual threatening, and they can be life threatening, depending on the type of autoimmune disease that they have. So what could be happening here? Already she told you that she's got rheumatoid arthritis. She's 49. Okay, it's not the right age. Usually they're in their early 60s. But this is scleritis. It's diffuse, it's superficial, and deep vessels are injected. Often than not, if it's this type of scleritis, whereby we call it the diffuse non-ischemic scleritis, it's usually bilateral eyes. Here, it's just a long haul. We need to explain to patients that this disease, it takes a full course of about 6 years, I think. So they'll have periods whereby like it recurs, there's relapse and remissions. And with time, you get the sclera thinning up. So this is the very same scenario a few years later. The sclera thins up. That's why you can see this blue tinge. So this blue tinge, actually, you are seeing the uveal tract. That's the uvea, just because the sclera has been thinned out. But interestingly, these patients never perforate. I know it might look scary, but they never perforate. So we just need to know what to do with these patients. So this one, like I said, we refer them, and then when they come to us, obviously we wake them up, you'll do a blood workup. It's very important. Inflammatory and autoimmune blood workup. Obviously, you can also add an infective workup just to be sure. But this is scleritis, like I said, they respond very well to NSAID, your typical Indosit, Volt, diclofenac, or Brufen. I mean, obviously, we'll have to cover for the GIT issues, but they do very well on NSAIDs. If they if the if there's no joy on NSAIDs, you can add steroids. But very rarely do I go to add steroids. Usually on NSAIDs, I don't, like I say, it usually they get flare-ups. They'll do well. You don't see them for a few months or for a year, and then they come back, they've got a flare-up, So you do this inflammatory wake-up, and obviously we'll refer accordingly. Often than not, with our patients, it's either rheumatoid arthritis, but now of late we get all these things. I mean, I saw a lady with Sjogren's. I mean, I've only read the thing in textbooks, and I found it like, wow, it's, yeah, And like I said, when you manage this patient, you need to explain to them the natural history of this course. It lasts up to 6 years, and then it has run its course, you know. Now I'm coming to the end of our talk, Doc. I hope I thought before I go to that I must talk about what I call the great mimickers. It's and you'll see why I'm using that phrase. So here's this 3-year-old. You, the cornea obviously is not so happy, but you can see cells in the anterior chamber. We call this hypopion. And one might say, gosh, this patient has uveitis. Actually, these are tumor seedlings. This patient has a retinoblastoma. These are cancer cells. So it's a great, it's a well-known, whereby like a person can think this person has uveitis, whereas it's not. And once it's like this, when you grade it, it's like, you know, they need treatment as soon as yesterday. So far for our retinoblastomas, we treat them in Cape Town. I'm not sure if we have a center in Gauteng as yet. They're still busy developing it. Here's another patient. I suppose here the telltale is that there's a bit of orbital involvement. But in most patients, they can just present with what seems like a subconj hemorrhage or like a hemorrhagic lesion, you know. This patient is actually, it's a vascular tumor. This is Kaposi sarcoma. And yeah, that's what I'm just saying, you know, it's scary just to see that you can see something like this, whereas you're thinking that you're dealing with something mild, whereas it's something more sinister. This is actually even more interesting. Uh, you look at this lesion, you might think this is the nevus, or because it's a pigmented lesion with good demarcations, but this is slightly raised. Actually, this is a malignant melanoma. And you might think of that. I mean, I'll just show you a patient of mine that this is from obviously the internet, but this is a patient that I presented during my reg time. It was a referral from she was actually in the neurosurgical ward because she had obviously mets in the brain, you know. Now, what's said about this patient is that she had those flat lesions 12 years ago, and she was seen and referred to a tertiary hospital, but she just felt that this is not serious. Now, this is what she ended up with. This is in theater now. After we can go back to the slide. So if you look at, you can see that this lesion is already involving the sclera, you know. So you know that that eye is gone. Yeah. We don't see malignant melanoma of the conjunctiva commonly in blacks, but it occurs in Africans and it's usually aggressive. This patient, I remember, I think within a few weeks or so, he demised, unfortunately. So, in conclusion, gentlemen, not all red eyes are due to conjunctivitis. A red eye can be a symptom of a local or a systemic disease. Appropriate history is very crucial for us to come up with a diagnosis. And the basic assessment tools are important for accurate diagnosis. And it's obviously important to note that there's many other important causes of a red eye that I couldn't cover today, but maybe we'll go through some questions and we can cover them, you know. Thank you. Thank you very much.
Awesome, 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 awesome. Dearest Dr. Mofokeng, for me, I tell you, the eye is one of those intimidating organs. And like I said, when we started, it's mainly because, we don't get a lot of exposure. But the reality is, there's many people and our dearest patients who at some point suffer, from this. So yeah, thank you so much. I think I really enjoyed this session. I really also enjoyed the practical side of it, especially when you took us through the scenarios. I thought that was very practical, and I could see as well colleagues engaged. And if you look at some of the feedback there, Najiba, thank you, very helpful. Hey, they are coming in so quickly. I can't even click one of them. Okay, Jolie says, wow. Okay, colleagues, I see that they are coming through, just for you to appreciate the impact. And I think we have over 800 health workers here. If you think of the impact of this session on the multitudes health workers are going to be assessing tomorrow, the day after. I think that's how we need to look at the impact of this work we are really trying to do. Colleagues, yeah, let's go through the questions. Okay, I'll start with mine because I'm the facilitator, so I'm taking all the rights. On your opening slide, I saw 64 to 68% of health workers who had in those and those are modern countries, or should I say the more developed countries, who said they were not very comfortable. And I also saw a very interesting one where you said we are likely to just say everything is conjunctivitis and see where that leads us. So where do you think we are in the South African context? I don't know, not from science, it's just your own perception. So Australia and whoever, they are at 64, 68% who say they are not very comfortable diagnosing or assessing the eye. Where do you think we are in South Africa?
Yeah, coming to think that obviously, we our medical training,
Yeah,
if I don't know now, but I think we adhere more towards the British style of training,
yeah.
and I think we are probably there as well. And I'll tell you why, if not even more. Uh, it's the issue is that even in undergrad, after module, we spend 2 weeks, if I'm
2 weeks.
not mistaken. Yeah, I don't know. I mean, during my training as a reg, it seemed a bit better in terms of the quality, but the duration is still 2 weeks. It's just that
Yeah,
they just give them an option to say in December you can come and join the
yeah.
department.
But
So,
it's
I think we are
Christmas.
there, if not, I think we're already there as well. We are
Yeah.
definitely around, if not more.
Okay, okay. Yeah, colleagues. So me and you, we have a lot to do in that space. And maybe some disciplines are easy to learn when you're already in clinical practice and you are seeing the cases. It's a pity we're gonna learn through other people's pain, but it's important that we keep on improving and getting better so that we don't repeat the same mistakes. Dr. Koza posted this even before we started. I think he wanted an answer. So if a patient has subconjunctival hemorrhage from trauma, do we need to treat or we can just do a watchful wait? What's your advice to that? Yeah.
Yeah, firstly, what's important is to assess the vision,
Mm,
you know. If the vision is intact, okay, let me put it this way. This patient has subconjunctival hemorrhage. Is it localized or is it diffuse? More often than not, they present with diffuse subconjunctival hemorrhage. Now, the problem with this is that
mm,
they develop what we call traumatic uveitis.
mm.
Now, if this traumatic uveitis is not treated on time, they complicate. They
Okay.
develop posterior synechiae, they can develop glaucoma and. But having said that,
Mm,
I myself, during my GP days, I used to see a lot of patients with subconjunctival hemorrhage. And the best things that I could do for them is to check their visual acuity, to note it down, to give them lubricants because or maybe analgesics. But ideally, if you look at the pupil, because the pupil will tell you if the pupil size are unequal, refer that patient.
mm, mm,
But in an ideal world, any blunt trauma should be referred. But I'm saying ideal world because we are not
mm.
in an ideal setup. But just cover your grounds. You
Yeah.
measure the movements because I mean you can imagine someone come with a fist and then he's got a floor fracture and there's muscle entrapment in that eye. So, but if you did the eye movements, you'll be able to pick up now the movements are intact. But
Mm,
if the globe is swollen, the movements are restricted. Just refer that patient, and somebody else must be able to say,
yeah.
continue treating that patient. or not.
Yeah, yeah. It does sound like our ability to assess carefully and making the call whether this is something you can treat or it's something that needs urgent care is probably more important for most of our patients. I think this was also posted before you posted your KS Kaposi sarcoma eye in your the great mimicas. But Mandla
Mm.
is asking, how common is that? Is this something you still see more frequent? I mean, from my world, And now we are putting people on ARVs very, very early. We are hoping these are very rare. But what is your experience in your setting?
It's extremely rare.
Yeah.
It's extremely rare. I only saw it once,
Mm,
and that's why I managed to remember this because it was actually one of my patients' case. And then when she showed me this, I was like, wow, this is actually scary because one could have, firstly, like you say, our patients now
mm,
are optimized on treatment.
mm.
Yeah. So no, it's very rare, man.
Awesome, awesome. Nokolo has a specific scenario for you. Doc, I have a client who complains that she has a problem with red, itchy, teary eyes. At night, when waking up, it feels as if the eyeball is stuck and can't easily open her eyes. What could be the cause? The patient is not diabetic and there's no history of injury.
Mm.
Mm.
Yeah, it's not called, I think you said. It's a
Yeah.
typical dry eye disease. It's a typical. I just forgot to mention that the eyes can be stuck together, but it's a typical dry eye disease. Like I said, you can give any lubricants, but if she wants me to be specific,
Mm.
I can give you what I prefer if a patient presents like that. So I prescribe. Is it fine to if I mention names, drug names?
We don't have sponsors, so yes.
Yeah, that's what I was declaring. That I mean, I'm just
Colleagues, we
yeah.
have declared
So
that we are just discussing clinical issues. No one has an influence. It's just advice. And
yeah,
two, please do note that you must verify your own treatment guidelines and stuff. Here we are discussing and we're giving advice so that you have an understanding of management approaches. Doc, let's push. Yeah, I'm happy.
yeah. So that patient, I'll start him here on a gel. So my go-to is what we call Xylene night gel. So and then they apply that gel at night before
Mm,
sleeping,
mm,
and then during the day, they can have any of the lubricants, whether is it Optive or whether is it Xylene HA, Xylene drops, but they must have a gel at night and drops during the day.
okay.
And then those drops, you can those lubricants, you can use them as often as you want. They are preservative free, so they don't have any side effects. But my go-to is that night gel, and I always say you must use that drop at least 3 to 4 times a day, especially when you're at work where there's air condition and everything. But
Mm,
that's I can without fear or favor. This is dry eye disease. That history alone.
mm, mm. Okay, thanks for that. Nokolo, I hope you were taking notes. We will discuss if there's a potential for a WhatsApp group for coaching. I don't know if Doug will ever have time because I'm always demanding his time so that you can send
No,
those
no, 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 no,
pictures
definitely.
and
Mm.
I think it's easier like that. But we'll have a
Mm.
side a chat, Doc. Yeah. Casey
Okay.
say, yeah, Kais says, as a GP, when are we supposed to refer red eye patient to ophthalmologist? I think you have mentioned it several times. Maybe your top three things that if you pick up, this is not your patient, please refer high up. What would be your top three, four things, Doc?
I think starting on the history, those red flags I mentioned,
Yeah.
uh, pulse, that if the patient presents with this severe unbearable pain. I
Mm,
get that kind of maybe obvious. If there's change in visual acuity, you assess this patient, if the vision is 6/6, then you know most likely this is something benign.
mm,
And then we mentioned about the light sensitivity, the photosensitivity,
mm.
and the
Location, bilateral, one eye.
yeah,
Yeah, I
yes, and
remember
then
that. I
yeah, like
remember that
technology.
slide.
But
Mm,
but the history will give you guideline. If you've
mm,
got the correct tools,
mm,
you get and like of anything. But if we could get ourselves fluorescent strips
mm,
and some anesthetic drop to use on those strips,
mm,
or even normal saline
mm.
and blue filter light, that
Mm,
will save
mm,
a lot of things for us
And
as well.
visual
VA chart,
acuity,
simple VA
minimal.
chart. I used to have a VA chart in my rooms. Yeah, yeah,
Yeah, it's not outdated,
mm,
colleagues. It still works.
yeah. No, that VA is very important. Thank you.
Yeah,
Yeah.
yeah. Do you ever consider systemic steroids? And when would that be?
As I mentioned, scleritis. the patient with scleritis that are not responding to the NSAID,
mm,
or if I feel that the scleritis is severe,
mm,
our patients on uveitis treatment,
mhm,
if we have a some of them you find that there's a underlying systemic cause, or you find that they are not responding to topical treatment alone. So uveitis and scleritis,
mm,
but both those scenarios, those patients should be treated in a specialist facility
mm,
because of the sequelae that can happen, you know.
mm,
Otherwise, after those things that we've mentioned, they're not commonly.
mm, mm.
But for a short
Awesome.
course, like I say, I mean, because even with patients with our VKC, whatever, they just do well. Or
Mm.
even simple allergic conjunctivitis, they do well on topical treatment.
Awesome, awesome. Now, yeah, I mean, you said fluorescent stains. I don't know, Kamohelo.
Strips.
Strips, yes.
Mm,
I mean,
mm.
these things are as cheap as they come. I don't know if there's anything, I don't know if there's any workaround. Doc, our health system is generally depleted. Most of us,
Mm.
we sort of know that we don't have enough to serve everyone. If we don't have these basics you are referring to, do we have workarounds? I mean, that's what Kabuhela is asking on how to identify corneal ulcers without the availability of your staining resources at level one hospitals. And they should have, it's a district hospital. But the reality is, yeah, we might not have.
You know, in my hands, for example, a corneal ulcer, I don't have to stain it, but I've got a slit lamp.
Okay.
That's my advantage, you see. So now the problem with the direct ophthalmoscope, it doesn't give you a full 3D. You can easily miss it,
Mm,
you know. So it's a tough one.
mm,
It's
mm,
really a tough one.
mm. Kamu?
Yeah, I mean, like I say, for me, even with a direct ophthalmoscope,
Mm,
if the patient has a corneal ulcer, I'll be able to pick it up. But I'd rather just because I've got the benefit of the slit lamp, I'll use that. But on this on the with just light alone, it might
mm,
not be possible.
mm,
It might not be. I mean, it's highly unlikely, because you will see that there's a bit of a defect. You will see that. But now the problem is that if this corneal ulcer is a big one, maybe like it's covering the entire cornea, it's a problem because now you won't see that.
you won't say it.
Uh, yes.
Mm. It will be like it's uniform. I think
Yeah, yeah, yeah.
yeah, I'm imagining what you are saying. So,
Mm.
Kamo, talk to the CEO, talk to the medical manager, get those strips. I think it's the best thing. Otherwise, work on your skills or get the right tool, and then work on your experience to get it right. Now, Olga posted this when you're talking about VKE and said allergic keratitis. Would this be close or would this be totally two different things? VKE and allergic keratitis.
Oh, I think I said VKC.
Sorry, VKC. Sorry, yes, VKC. Yeah.
Yeah. And
Mm,
then I said it's venal keratoconjunctivitis.
yes.
And then when I talk about keratitis,
Mm,
uh, it's not the same thing. Let me just put it like that.
mm,
So basically, when you talk about these corneal ulcers, we use the term loosely. We can just say it's a corneal ulcer due to a bacterial keratitis or due to a viral
okay.
keratitis or due to, yeah. So it's not, so VKC is a very mild condition. Once we say keratitis, we worry.
It's serious, ne, Olga?
Yeah.
That's serious. Okay, this one is a request from Brenda. Says, can we please, and you can see there's please and kindly in the same sentence, following each other. Talk on glaucoma and cataracts. This talk was excellent. Thank you. Okay, Brendan, we have noted your request, glaucoma and cataracts. All right, but cataract has so many causes, but we will see. So participant says, what can you give to make the brown conjunctiva white again? Can it be white again? But my son had this, it's now white. He's now what,
Yeah,
eight? Yeah.
mm, mm. Yeah, no, it's just persistent. Like I was saying, that we need to counsel patient that it's a long haul.
Mm,
Uh, the brownness is the last thing to go. but it does go away.
I
Yeah,
mean, I found that few things. One, adhering to the treatment. And then number two, teaching my son not to,
to
to
scratch.
say, yeah, because I noticed that if he scratches, it's like the feeling makes you to want to scratch more, or it's nice or something. I don't know. But now I see he's managing to avoid it, but I always help him. But so far, so good. I know it's not like he's out, but at least there's something there.
Mm. Mm.
And then the same resource limited settings. We don't have mast cell stabilizer, neither do we have steroid drops. At PHC, what must work around?
Yeah, maybe if I come in there, because I mean I obviously worked
Yeah,
in the state for a while before going full-time private.
yeah,
You know, we tried to involve basically the referring clinics
yeah.
to obviously to St. John, because I was in Soweto.
Okay.
And we obviously, because that's a management issue, we obviously, because we have a workload in our tertiary hospitals, and
Hmm.
the last thing you want is to have a high workload on something that can be controlled at
Lower down.
the healthcare level. So all they wanted us to do was to confirm the diagnosis and send them out. So in our draining areas, I know a few clinics, we end up having to tell them that this is what you must order,
Hmm.
this is what you must stock, you
Hmm.
know. And if they don't have those things, what we used to do, they used to write them the script, and the patients will come all the way to St. John's, unfortunately,
Hmm.
just for them to collect the script and go back home.
Yeah. No,
So
that's
sometimes I think we need to make the noise, to
yeah.
say, you know what, this is, as a doctor, this is how far I can go. Do your part, do your
Hmm.
part. Yeah, these patients end up going to, like I showed you the endpoint, they
Hmm.
end up having all those
Complications.
corners.
Hmm.
Yes, and then
Hmm.
it's really not necessary. And whilst we're still there, before you go to another question, I thought somebody's going to ask about, artificial lashes. Maybe somebody, because I've seen.
Artificial. Yeah. Yeah. Yeah.
Yeah, because sometimes what happens is that I think the glue that they use, some patients can sometimes react to it, but sometimes they come, you find that the eyes are stuck together. I don't know what would have gone wrong there,
And then glue.
and people are in a panic. So I
Hey.
always say, first line is, if you give them lubricants, your topical Cloramax, whatever,
Yeah.
with time that glue crystallizes. But if it persists, we have to cut
Yeah.
them open. Yeah, we literally cut, yeah, but yeah, that's also one of the common things whereby like patients can have a red eye from this artificial lashes, but
Hey.
you treat like you treat another allergy.
Too many courses, dog. So yeah, and
Mm.
I think the dry eye you responded to, right? You gave Unotolo at that time a number of things they can use. Maybe you can mention your single preferred eye drops for dry eyes.
Yeah, you're putting me on the corner. So for now, my
Hierarchy.
favorite one,
What's at the top?
yeah, is Hilo Dual Intense.
Okay. Hello,
Yeah.
Jewel Intense. Okay.
Mhm.
Okay, saying here that's the preferred one. If you have a follow up,
For
type in.
me,
Yeah, it's a personal preference, right? Yeah,
yeah, my patients are happy. Those that I put on it. Yeah.
yeah. Olga, history of hard work, lifting up something heavy, pushing. I think it was the subcon.
Vasalva, yeah, the
Yeah, yeah. I think
subconjugation.
that's
Yeah.
what Olga is referring to. And I think on the same scenario, I suspect she was asking what is the intraocular pressure, fundoscopy. I'm not sure. Maybe you'll understand where Olga seems to love the eye. Olga, do tell us if you're the eye doctor as well.
So what was the question? What will be the findings of intraocular pressure and on a
Yeah, I
patient
think
with
on the
subconjugation?
subcon patient, I might be wrong, but yeah, yeah.
No, 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 no. We expect the pressure to be normal
Okay,
because
okay.
the I want to say the physics behind this. Remember, the Valsalva is that increased intrathoracic pressure that's pushing the small vessels upwards, but it
Mm.
has nothing to do with the pressure is normal.
Okay, awesome, doc. Uh, Nginzi Mongameli says, are there any specific red eye conditions common in people living with HIV? Kaposi, we said it's not common. Is there something that you see a little bit more frequent?
No.
Yeah, no, today, no. We shouldn't be seeing anything. In the early days, yeah.
Yeah, not in this day and age. Yeah, I mean,
Yeah.
the one thing that we see,
Mm.
it's I just didn't want to talk about it because of time. This CMV retinitis,
Retinitis,
you know,
yes.
yeah, cytomegalovirus and HSV and all those. But now with the advent of HIV, those patients don't CMV. We get in patient the CD4 count must be less than 50.
Mm.
But now, the HSV retinitis, which can also cause a red eye, it's on patients who are uh, immunocompetent.
Okay. Mm.
So I think the answer to this is just no, to be
Okay.
honest.
Awesome.
There's none.
Valerie says you mentioned that you would give an antibiotic ointment anyway because of soothing effect, etc. Oh, now I'm answering the question. But her question is,
Yeah, yes, you are right.
her question is, why are you
And
using antibiotic in a viral conjunctivitis? But I'm replaying what I heard. Yeah.
yeah, and actually, that's why when I put that statement, I put a question mark on it
Yeah.
to say, I mean, even in the literature, I mean, if I was going for an exam, I wouldn't say this. I
Yeah.
wouldn't mention that part. But now I'm talking from in terms of experience of myself and my other colleagues. I know I'm not the only one. We just give it, and it's really. Remember, I mean, it's for short term. I know people can talk about resistance and what, but chloramphenicol, it's our entry level. It's just to it like I say, it gives them that. And interestingly, I was given this very same advice by a professor, who was a professor who was very big on cornea and everything. And he said, "Tabi, so just add this Ploramex. I know this is not a bacterial thing, but you just add it." And yeah,
Yeah.
so yeah, so
So it's
she mustn't
practical
worry about it.
advice.
Exactly, exactly.
Okay, colleagues, we're left with 5 minutes. We don't have diploma coaching programs, so now I'm able to rest. I'm actually recovering my energy a bit back because during the 3 months, 12 weeks where we have this diploma coaching programs, I'm telling you, yeah, I take a lot of punches from just sleeping late every single day. Makito says, sorry, doc, in most of the cases of red eyes, after a proper eye examination, giving NSAIDs and ceftriaxone IV and good counseling, after 1 or 2 weeks follow-up, it usually ends well, but patients are very concerned. Can you advise? They're concerned. So they've healed Makito. Are they concerned that it will come back? And I wonder which condition you are referring to. NSAIDs, is it the NSAIDs, is it the rheumatic
Because he also mentioned IV. I think he
ceftriaxone?
said so. Yeah,
Yeah.
because I mean, for the only time I have where I want to give patients IV is when I think about things like your STIs, gonococcal conjunctivitis. Because even patients with corneal ulcers, when you admit them, we
Mm,
still don't give them IV. We give them topical drops. So, the only time we give people IV, it's either for me, I mean, I'm just thinking either a patient with a gonococcal conjunctivitis,
mm,
or if it's a patient with endophthalmitis,
mm,
but obviously those ones often than not, we take them to theater as well because we,
mm.
we want to do a PPV for them. So I'm not sure, maybe if ever you can elaborate
Yeah.
which conditions specifically are. But maybe whilst I have you on this one, Doc, because you said 5 minutes,
Yeah.
I thought somebody might ask this. Stephen Johnson's, we must always remember that Stephen Johnson's and
Yeah.
10, those conditions, please let's not forget about the eyes. I
Mm,
mean, I've got a young man that I'm treating all the way from Pumalanga who's now needs to have a major expensive procedure
mm,
because they treated everything else and forgot about the eyes. Stephen Johnson's, it affects the skin, the eye has a
mm,
conjunctiva.
mm.
It's the same mucous membrane. They get severe things that can be prevented, you know?
Awesome.
So. Even they're in ICU, let's not forget about their eyes.
Here's your distinction question. Remember, I told you that I have a distinction question for you.
Yeah,
And I'm
yeah,
gonna start it this way. Pink eyes. What is that? Mari, I went to the doctor. The doctor
yeah,
said I have pink eyes. Is that
yeah. No,
what is
I
that?
sometimes also use that word when it's a viral infection. It's usually adenoviral.
Yeah.
Yeah,
Okay.
it's a
Now,
viral conjunctivitis.
yeah. Now at the summit of the distinction question, you know about pinky
Mm.
pink.
Sorry about.
You know about pinky pinky. When I grew up,
I know it was something on
when I
TV,
was
but
at
I can't
school,
remember.
they said there was pinky pinky, and all kids at school had pink eyes, and he was somewhere in the toilet. You know, Shem.
Mm-mm.
Was it the infectious conjunctivitis? or what was happening?
It was definitely it's definitely viral. That's
Look
why
at
it's so
the
highly
old
contagious.
people there laughing. Everyone who's laughing, it means you are 40 years
Mm.
plus. You can't do pinky
Yeah,
pinky if you are younger than that.
yeah, no,
So it was an
it's a
outbreak.
viral.
It was an outbreak in many schools at the same time of pink eyes, basically.
Yeah, and then if you follow it up, you find that most of them is during the flu season, like
Okay.
I was saying.
Okay.
Yeah.
No, I thought Pinky
Mm.
Pinky was real. This Pinky Pinky guy, whatever it is, I don't know. Anyway, no, you passed the distinction question, dog. So you are
Thank
good.
you. Thank
Because
you.
this one is not they go med. They don't test you
No,
for Pinky
definitely.
Pinky.
Yeah, definitely.
All right. So, and linked to this, then it's Neo's question about Specialage because it is the most available eye thing in the public sector. It's probably very cheap as well. Chronic
Mm.
use, are there any problems with prolonged use of Specialage?
Special edge will work very well in a patient with VKC, remember, and
Okay.
they need long-term treatment.
Okay.
The only thing that I feel is that they will also need to have a muscle
Marcel.
stabilizer,
Yeah.
like your paternal or something like that. But if they're
Awesome.
doing well on special edge alone,
Yeah.
that's good. Yeah. But there's
Awesome.
no long-term, yeah, yeah.
Okay. So let me see this one. It's talking about I think shingles or something. A patient with facial herpes zoster is given correct dose of acyclovir, then comes back with a red eye after completing treatment. What's the way forward after completing acyclovir? So this patient had herpes zoster, I guess, and was given the
Mm.
correct dosage for the right duration. But after completing treatment, now has a red eye. So the question is, do I need to restart a cyclovir or how? Basically, talk about the evaluation of any post-hepatic zoster complications. I don't know, related to the eye. What may
Yeah.
happen? Yeah,
So,
yeah.
yeah, obviously I'll have to refresh my brain nicely on this one. But I can tell you now that it can happen. And once it's happened, you need to put them on what we call maintenance therapy.
Mm,
So what I mean is that just need to refresh my memory in terms of the dose. But the dose of maintenance is
mm,
much lower than on of
lower.
the therapeutic.
Mm,
So you have to start them again on the therapeutic dose. And because I mean, and one of the indications to put them on maintenance therapy is if it recurs. So
mm.
already she's already mentioned that it has recurred. So you put them on maintenance therapy.
Yeah, awesome. Colleagues, that's it. That's it. I really, really, really tried. And I see people are talking about recordings. Yes, Joanne. The recordings are available. The recordings are available. You must be a member of the platform. Yeah, colleagues, I see there's still more questions, but I think most of you are happy that we have seen this. And Devaling says, I am so touched. I've seen some of the eye conditions presented. Thanks for the unique presentation. Unique cause we really ignore our eyes. You see, Doc? Very
Yes.
positive. Ndibaleng
There's
is left inspired. Yeah, Michelle, Mikhail, Julia says, thank you so much, Doc. Veronica says, thank you, Doc, for an informative session. Yeah, colleagues, if we have not answered your question, I must say my sincere apologies. Now, before I ask Doc to do his closing remarks, just to remind you, visit our website, join the membership program, get empowered, get access to recordings, get your CPDs, let us report your CPDs to the council. We don't talk about those things. Members know that is assured, so we really, really want to encourage you to join us on this journey. Actually, I had a poll which I wanted to run. Colleagues, don't leave. I want to ask you a question now that I remembered. Where is it? How many of you would be interested to complete the College of Medicine Diploma in Ophthalmology? If you're not sure like me, click not sure. If you say no, it's a no. If you say yeah, maybe, or yo, I'm so scared of the eye. Look at that dilution, dog. I don't know if you can see. It's like a
Mm.
horse race. But I think we have enough number of people who might be interested. So it's something that we will look at. Let me show you what you guys are saying. Many of you are not sure because you haven't visited CMSA to go and see what this is all about, or you are still saying, "Oh, the eye, I don't want to see the eye every day. It's too microsurgery, too small suturings." But there's at least 57 of the 100 people who responded who say, "Yeah, I might want to consider it." So yeah, we will let you know if it's something we are able to offer. The last poll is about membership. So, are you interested to join the CCP membership? Type a yes there. If yes, 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 I think I really want to join, or nah, I'm already a member and I'm so happy the way I am. So, yeah, okay, let me give you 8 more seconds and we call it a night. All right. So there's few of you. Let me show you your results. I think it's going to be interesting that most of you are already members of the platform. A small percentage are like, why? Why must I join membership? No, I'm not sure. 1% are like, very sure. No, I'm fine. I just want to enjoy this learning. And there's like 31% who say, Dr. Mawela, send me a WhatsApp and let's talk about membership. So tomorrow I'll allocate an hour and call all of you and yeah, and then maybe ask you if you have specific questions. I thought I was gonna have a post webinar session with you and say stay behind. Please expect my voice. Hello, good morning. It's me, Dr. Mawela. You remember what you said last night? No, I don't remember. Okay, Doc, your closing remarks. We call it a night. Thanks, colleagues.
No, no, no. Yeah, thanks, Doc, and thanks for the very lovely questions as well. We'll look into the issue of glaucoma. I mean, glaucoma is very close to my heart. But like I say, I always want to present things and make them to be as practical as we can. So I need to come to see if I can have a practical angle to it,
Yeah.
Because there's no point in talking about something whereby, like, in our day-to-day clinics, won't be able to diagnose it because of the lack of the equipment that is.
Yes.
So, but yeah, I will really, but anyway, we'll chat, me and you, because I mean, there's many other things that you want to do. So we
Yes.
will see, but we'll try to make this as practical as we can, because that's, for me, that's important as well.
Awesome, awesome. Lydia, send us an email, info@clinicalcareplatform.com. I see you say you are not sure if your membership is active or not. Just send us an email and then we will take it from there. Colleagues, on that note, this is time to spend with your family or with yourself. Remember, our leadership note today says treasure the moment, right? Appreciate this moment because that's what you know you have. The moments that pass during the day, there isn't much we can do. This day is not yet over. We still have 4 hours before midnight. But we are not assured that we will see tomorrow. So treasure this moment. Do what you need to do. Spend it with your loved ones. Spend it doing something great to develop yourself. Whatever it is, Treasure it. Night, night, colleagues. Till we meet again on Thursday.
Thank you.
Bye.
Thank you. Thank you.
Bye, colleagues.
Bye-bye.
Thanks, Doc. Blessings.
Thank, thank you.